Hey guys, hope I'm audible as well. It's Matt Killer Gaming. Yeah, you are absolutely right. That's what is the definition of metastasis. Amazing to see the definition right in front of me when we start the discussion on metastasis, right? So let's go to the final hallmark, which is the metastatic potential of a cancer. Right? Like the gaming guy said, metastasis is nothing but the property of cancer. It's seen only in cancer. Good evening, lion. Where it's going to move from its own location to a different location high up enough. Let's say I'm having a skin cancer. The skin cancer moving to an axillary lymph node is also metastasis. Moving to the brain is also metastasis, right? It has to go from its location to a different location. That's all. Good evening, Nayak. So I think we had briefly discussed about the roots of metastasis in the initial lectures. Just to revamp once again, I'm going to ask you questions and I want you guys to answer. Which type of tumor do you think will spread via lymphatics? Carcinomas or sarcomas? The three main routes of metastasis. One is via lymphatic route. The second is lymphatics, obviously, to the lymph node. Hematogenesis via blood. Right, that's what hematogenesis means. It's going to transfer via blood. Great, great, lion. Carcinomas prefer lymphatics, right? That's absolutely right. Most of the time, carcinomas prefer to spread via lymphatics, and that's the most common route of metastasis as well. Okay, I'm good, Sagar. Hope you're doing good as well, right? So whenever let's say you're going to your surgery department, you're seeing a patient with breast cancer. It's by default you have to examine the axillary lymph node. You're seeing a patient with a foot in the ulcer or a malignant ulcer in the foot. You have to go and involve or examine the inguinal lymph node or the popliteal lymph node, right? Because almost every carcinoma has a chance to spread via lymphatics. Mainly sarcomas spread via blood. I'm not saying the reverse is not true. Sarcomas can also go via lymphatics. Carcinomas can also go via the blood, right? But the predominant route of spread is like this, right? When I say seeding of body cavities, we also call it a direct spread. So direct spread means, let's say from a lung, it goes to your pleural fluid. That obviously is your direct spread, right? From the lung, it escapes, right? Scare is a mnemonic for sarcomas which spread via lymphatics, right? So from lung going to pleural fluid is a direct spread. From pericardium or the heart going to the pericardial fluid is a direct spread. From a colon going to the peritoneal fluid is a direct spread. It just expands, that's all. Can a bladder be in touch with the sigmoid colon? Is that statement right? Anatomically they are very close, right? A bladder cancer can go to sigmoid, direct spread. It's not always cavities alone. Can a uterus be in touch with bladder? It can, right? So uterine cancer going into bladder is also a direct spread, right? So direct spread means it's not having any route. I'm having two organs adjacent together. It can go here. That's what, or seeding of body cavities. Sometimes it'll be body cavities. Sometimes it's just the adjacent organ. Those are the three major routes of spread. Today's class goal is to learn about the steps involved in the metastasis, right? So like I said in the start, the goal is for a cancer to spread to a different organ, right? That's a goal. So there are 6 primary steps of metastasis. We look at all of them one by one, right? Let's assume this is a cancer. Let's assume this is skin, not a very good skin, and this is a squamous cell carcinoma. That's obviously the malignancy of skin, right? So when you have a squamous cell carcinoma, we have to understand how do they spread, right? So the first and the most important thing to call it a cancer is, one is metastasis. Can you guys answer what is the other thing for me to call it cancer? Dash and metastasis are hallmarks of cancer. There are two things which are hallmarks of cancer. What are they? Invasion and metastasis, right? So the first thing here is it has invaded the basement membrane. It has gone through the basement membrane, gone down, which means I know for a fact it's a cancer. Now tell me, which is ideal for this cancer? The entire lump of the tumor, let's assume it's going to the lung, right? Let's understanding it's going to the lung. Tell me, the entire tumor going to the lung, or one or two cells breaking and going into the lung, which you think is logical? Entire tumor or some of them? Definitely, if I have one or two cells breaking and going to the lung, it means it feels logical, right? It's difficult for a 2-3 centimeter tumor to spread via the capillary and go to the lung, right? The first step of metastasis, loss of E cadron. If you're writing an essay question, if you have all the 6 steps mentioned, that is the first thing, right? So loss of E cadherin is first thing, and this has come in an MCQ, the first step in metastasis, right? Once E cadherin is gone, that's a cell adhesion molecule. So I'll have a metastatic clone of cells. So let's say I have like million cells in a cancer, like 100 of them will have a E cadherin loss or a mutation of E cadherin. So I have metastatic clone of cells. So all these cells are single because there are lots of loss of E cadherin, cell adhesion molecules lost, they become single cells. So it's much easier for them to break from the main tumor like this. They become like this, right? They become like this, tiny, and they are lost. So they are individual cells. Clone means, like I said, it's a mutation, right? So mutation happens. I told for an example, I have 1 million cells. Just for a random example, in this, let's say 100 cells have the mutation. So these 100 cells are having an extra mutation compared to the rest of the cancer. This 100 cells, I call it a clone, right? Understood, Laya? Hi, Punit. So this 100 cells can or will have the capacity to spread whatever happens. I'm having a clone because if I have only one cell, it's very less likely it will destroy, right? So that's why I have a clone of cells, right? That's the first thing. So once I have a clone of cell, the second thing for me is I have single cells. Since we took an example of a squamous cell carcinoma, all these single cells are going to be in the dermis. So this is a big concern. A squamous epithelium cannot destroy dermis. If it cannot destroy dermis, it cannot go through at all, right? So this is where my second step, which is destruction of stroma or an extracellular matrix. The stroma has to be destroyed. Hi, Utsav. Only when the stroma is destroyed, it can go inside, right? Okay. Fine. So I have to destroy the stroma so the cell can spread and go to a different organ. The stroma here, dermis, is made of collagen. The way to destroy the stroma is these macrophages will help me, right? So in any tumor, you'll have lots of macrophages. So the macrophages secrete a few substances called as MMPs. Can anyone expand MMP? We read them long back in wound healing chapter. Under the MMP, I have few examples of enzymes. One is collagenases. There are lots of them. Gelatinases. All these are MMPs. MMP stands for matrix metalloproteases, right? Perfect line. So the macrophages, which is there at the site of the tumor, they secrete matrix metalloproteinases. So collagenase is a matrix metalloproteinase, gelatinase is a matrix metalloproteinase, right? So these guys will destroy stroma. So that there is a MCQ once asked, or it can come in a Viva as well. When you see macrophage at the site of tumor invasion, good prognosis or bad prognosis? Whenever you see good amount of macrophages, it's a poor prognostic factor because they are going to help in destruction, right? Punit, there are quite a few lectures available on YouTube. You can just go into it, and there are lectures available in the Medit platform as well. You can download and have a look at it, right? Okay, so that's what about your matrix metalloproteinase, or second step, the destruction of the stroma. So once the stroma is destroyed, I have a gap formed here, right? So the destruction of stroma gave a cell a gap to escape. Now the concern here is it's an epithelium. An epithelium cannot and will not move. My skin doesn't move. Skin always stays here. My hand moves. Muscle helps me to move. Epithelium doesn't move, right? My GI epithelium doesn't move, but the muscle layer causes peristalsis. So which means only a mesenchymal cell can move. That's my third step. The third step here is EMT. EMT stands for epithelial to mesenchymal transition. I have something called an epithelial to mesenchymal transition. This happens only after invasion. This happens only after destruction, right? The two genes which converts an epithelium to a mesenchyme, it's called as twist and snail. These are embryonic genes. Actually, in adult life, I don't see them most often. Maybe when there's a trauma, I can have them. So these genes are again reinstated. So an epithelium becomes a mesenchyme. So when they become a mesenchyme, am I right in saying that I can have actin myosin? Is that statement right? Definitely, right? Every mesenchymal tissue will have actin or myosin component. With the help of this actin and myosin component, automatically they will have the capacity to move, right? So it becomes a mesenchyme. They'll acquire actin, they'll acquire myosin, They'll acquire lots of new proteins which helps them to slowly move. Because only a mesenchymal tissue can move, right? So it kind of becomes like this and slowly moves. Just a way to remember, epithelium is always like round or polygonal. How do you draw a mesenchymal cell? We draw a mesenchymal cell like a spindle shaped structure, right? Just maybe remember like this. The cell epithelium twists itself for twist and moves like a snail. It twists and becomes an elongated spindle shaped structure. So those are the two genes, twist and snail, which helps in the movement, right? So now it has moved. It has moved and came to a blood vessel. There's a blood vessel there. It has come to this corner of the blood vessel. So now what it will do is it will destroy the blood vessel's outer membrane and then it has to come inside, right? It has to come inside like this, right? That's my fourth step. Entry into a vessel or a lymphatics. I'm taking vessel, but the same will be the step for a lymphatics also, or the formation of a tumor emboli. So here I have a mechanism for a tumor emboli formation. Let's assume, I'm just going to zoom this part alone. Let's assume I have a cell which is damaging the blood vessel from outside and coming inside. Can I say in this process endothelium can get damaged? Yes or no? Definitely yes, right? So whenever endothelium is damaged, what will my body do? Whenever endothelium is damaged, what's the reflex of my body? It's the same thing. Whenever you have a damage to the endothelium, automatically it will result in a perfect. It will result in your clot formation. It will have a clot formation for sure, right? Perfect. So whenever an endothelium damage, it will result in a clot formation, which means the clot here will help to bind the tumor cell. I have a tumor cell here. So this tumor cell will be surrounded by platelets. Obviously, you'll have clots, you'll have platelets, you'll have WBC stuck to the surrounding, RBC stuck to the surrounding as well, right? You'll have tumor emboli formation, which is composed of platelets, which is composed of WBC, which is composed of tumor cells as well. So tumor cells don't go alone. They are always in the form of an emboli. This is how tumor goes inside a blood vessel or a lymphatics. They go just like that, right? So once we have this, the reason for this is, so once you look at a tumor emboli, the outermost cell, it's a very calculated step. Outermost cell, all for tumor emboli is always WBC because it has gone into a blood vessel or a lymphatics. A RBC cannot exit a normal vessel. It can exit only when there's a trauma. A platelet cannot exit a normal vessel even in a trauma. The only cell which can exit a normal vessel is WBC. If you remember acute inflammation, rolling, addition, diaperesis, WBC can exit for sure, right? So what happens here is the outer surface is made by WBC. So if there is any inflammation here or any chemokine here in a particular organ, the WBC here on the outer aspect will move outside. When the WBC moves outside, the tumor emboli also moves outside. That's my fifth step, chemokine mediated exit. Okay. The classical chemokine mediated exit. It goes outside with the help of a chemokine. That's very, very important. We have understood about one chemokine with good amount of confidence. A chemokine called as CD44. It's also a receptor for hyaluronic acid. This is seen or this is overexpressed in cases of lymphatic spread. Whatever may be the cancer, in case of lymphatic spread, hyaluronic acid is overexpressed, which means my ambition or my goal is to create an antibody to hyaluronic acid, destroy that in the lymph node so that I can destroy lymphatic spread. That's the reason why we have to learn about the pathogenesis so that we can have an outcome, right? So once chemokine has an exit, next goes my sixth step, the metastatic organ. There are few things which are very, very common for every metastasis. So I told the exit is based on chemokine, which means can I say almost every time it will have the same effects like an inflammation. Only because of inflammation they're going to go outside, right? So inflammation happens in a big vessel or a precapillary venule or a postcapillary arteriole. Where do you think inflammation happens? Like a place in aorta or in a precapillary or postcapillary venules? It happens in the venules, right? So almost every time inflammation happens in the tiny vessel only. They cannot happen in a artery like a pulmonary artery. That's why all Mets organ are in periphery, right? So they start, I gave an example of from a million cells, 100 of them is having E-cadherin loss. which means all 100 can spread, right? So Mets will be single or multiple? They'll always be multiple because it's very difficult for it to go. So why should I go with one and then fail and do it? Let me do everything. Whichever has been successful, they'll have a deposit, right? It will always be multiple deposit. They'll never be single deposit, right? And most of the time, they'll be very, very, very well defined. Okay? This can come in an exam. Remember this. There's a chest X-ray finding. I'm writing CXR for chest X-ray. A finding called as a cannonball secondaries. If you have a cannonball lesion, this means I'm talking about lung metastasis. Cannon is your, I'm sure you know what is a cannon, right? No, wherever I use metastasis, it's the metastatic organ. Here, mets means metastatic organ, fine? Okay. The cannonball is the firearm, right? It looks round, exactly round. So the lesion looks exactly round even in chest X-ray. Whenever you see cannonball lesion in a chest X-ray, think of a lung metastasis, right? It's always well defined. These periphery, multiple well defined nodules, diagnosis of metastasis in any scenario which comes in a university exam or even an EPG exam. Remember that always, fine? Now here, there are few organs which I want you to remember in terms of metastasis: lungs, liver, brain, and your heart. The lung, liver, brain, and heart. These four organs, metastasis are more common than primary. So I'll tell you what do I exactly mean by this. So in these four organs, let's say lung metastasis is very, I'll do it like lung metastasis is more common than lung primary adenocarcinoma. Brain metastasis is more common than glioma or meningioma. That's what I mean. In all these conditions, mets are more common than primary, right? So what do I mean by well defined is, see, I told it's a peripheral tumor, right? It'll be like this. It'll be like this. It'll be like this. It'll be like this. If you remember our first chapter on neoplasia, your cancer will be infiltrative or defined. It'll be infiltrative. Generally, when you see a well-defined lesion or a completely, there's no infiltration, very well defined, you think of a benign tumor or a malignant tumor. We always think of a benign tumor, right? Whenever it's malignant, it will be infiltrative. Malignancy will be like this. It will be infiltrative, right? It will always infiltrate. But remember, cancer is a marker of malignancy. Sorry, metastasis is a marker of malignancy for sure, but they will be well defined. That's what I want you to think of. This is very important because when you go and sit as an intern, you see a chest X-ray, two exactly round nodules. Don't think of a benign tumor. Think of a metastatic deposit, because mets will be well defined like a benign tumor, but mets will be multiple and periphery. A benign tumor generally will not be multiple, single lesion, right? These are clues for me which you might miss, because whenever it's well defined, it's benign for me. Here it is malignant, fine? That's what I mean by well defined. Clear, Lion? Yes. So these are the characteristic findings of metastasis, right? Let's go through once again quickly. 6 classical steps. It definitely can come as an essay question for you. Write the steps, and if possible, put a diagram as well, right? The first, I have a cancer. It has to break down into tiny things. A loss of E cadherin, becomes a single cell, goes to the dermis. I cannot destroy the dermis, so macrophage helps us and gives matrix metalloproteinases, collagenases, gelatinases, which destroy the stroma. Once it's destroyed, I have an epithelium which has a way, but it has to move. Epithelium cannot move, so it becomes mesenchyme. With it twists itself, that's the first gene. Moves slowly like a snail, that's the second gene. Twist and snail help them to become mesenchyme. Once they become mesenchyme, they gradually move either towards lymphatics or towards a blood vessel. If it goes to a blood vessel or lymphatics, it destroys from outside and they come inside. Once they come inside, they'll damage endothelium. When they damage endothelium, by default, it has to trigger clot formation, which forms a tumor emboli. Inside the circulation, tumor cells never travel alone, they always travel as an emboli, so that they are safeguarded from the immune cells, because blood has WBCs. They're not destroying them, right? Because they're safeguarded, surrounded by WBCs. So my body thinks they're WBC. Second thing is, only WBC can exit outside. The next is chemokine mediated exit. So the tumor emboli has WBC surrounding them, So with the help of the WBC, the tumor cells piggyback along them and go to the distant side, be it a lymph node, lung, liver, brain, whatever it is, right? So once it goes to the distant organ, almost every mets will be in the periphery. They'll be well defined and they will be multiple. These are three characteristic findings of any metastasis in any organ in the body. And lung, liver, brain and heart, always think of metastasis first rather than the primary cancer, right? So these are the 6 classical steps of metastasis, right? Okay, any doubts, do let me know. With this, we complete all the classical required hallmarks of malignancy. Few of them I have not done, but they are very, very simple, right? I am sure you'll be able to cope up with them, right? Yeah. Okay, Jay, so I'll see you soon. So for all essential bachelors, see you by 7:30. I have lots of practical slides for you. Hopefully, we'll be seeing the slides, zooming it, and learning more from that, right? Thank you. Bye bye.